Constipation is defined as a decrease in the frequency of fecal elimination and is characterized by the passage of hard, dry, and sometimes painful stools. Normal stool frequency ranges from 3 times daily to 3 times per week. Patients may experience abdominal bloating, headaches, low back pain, and/or a sense of rectal fullness from incomplete evacuation of feces. Epidemiology of constipation. Constipation is common in all age groups, however, there is a higher prevalence in people 65 years of age. Women suffer from constipation more often than men. Constipation can be caused by many factors including a diet insufficient in fiber causes constipation. Second cause is inadequate fluid intake. Similarly, lack of exercise is also the main cause. Poor bowel habits, such as failure to respond to the defecatory urge or hurried bowels, for example incomplete evacuation, can contribute to constipation. Medications may also cause constipation, such as narcotic analgesics, diuretics, anticholinergics, antidepressants, antihypertensives, antihistamines, phenothiazines, antispasmodics. Iron supplements, calcium or aluminum containing antacids, non-prescription non-steroidal anti-inflammatory drugs, histamine 2 receptor antagonists like ranitidine. Pregnancy is a common contributor to constipation. The increased size of the uterus, hormonal changes, intake of calcium and iron containing prenatal vitamins, and a reduction in physical activity are all considered contributing factors. Systemic disorders, such as intestinal obstruction, tumor, inflammatory bowel disease, diverticulitis, hypothyroidism, hyperglycemia, irritable bowel syndrome, cerebrovascular disease, or Parkinson disease are also risk factors. Now coming towards treatment of constipation. Non-pharmacologic treatment includes increased intake of fluids, at least 8 servings of non-caffeinated fluids daily, and fiber, e.g., whole grain breads and cereals, beans, prunes, peas, carrots, corn. The recommended adult intake of fiber is 20 to 35 grams per day, but individuals who are consuming inadequate amounts of fiber should increase the amount of fiber intake slowly to prevent gastrointestinal distress. Increase exercise to increase and maintain bowel tone. Pharmacologic treatment of constipation. Recommendations for simple constipation should begin as a stepwise approach with bulk-forming laxatives as first line, hyperosmotic laxatives as second line, and then stimulant laxatives if the previous recommendations were ineffective or intolerable. Self-care for the treatment of constipation should be limited to 7 days. Bulk-forming laxatives are natural or synthetic polysaccharide or cellulose derivatives that adsorb water to soften the stool and increase bulk, which stimulates peristalsis. Bulk-forming agents include psyllium, e.g. Metamucil, Consul, Fiberol, methyl cellulose, e.g. Citracel, calcium polycarbophil, e.g. Consul fiber caplets, Fibercon, and wheat dextran, e.g. Benefiber. All bulk-forming agents must be given with at least 8 ounces of water to prevent choking. Another class is hyperosmotic laxatives, which work by creating an osmotic gradient to pull water into the small and large intestines, resulting in increased peristalsis and bowel motility. For example, glycerin, polyethylene glycol, lactulose. Stimulant laxatives work by altering water and electrolyte transport by the intestines and by stimulating bowel motility. They are recommended for relief of constipation when an individual has failed or is intolerant to bulk-forming or hyperosmotic agents. However, stimulant laxatives are being used more frequently as first-line therapy for opiate-induced chronic constipation, e.g. senna, bisacodyl, castor oil, cascara sagrada, aloe vera. Emollient laxatives, also known as surfactants, work by allowing water to move more easily into the stool. This creates a softer stool, which is easier to pass. Thus, these agents are particularly useful in those who must avoid straining to pass hard stools, e.g., recent myocardial infarction. Rectal surgery. Emollient laxatives have very few side effects, but they are not as effective as other laxatives, e.g. docusate sodium, docusate calcium. Saline laxatives, which include sodium and magnesium salts, work to draw water into the colon. This class of laxatives includes magnesium citrate, magnesium hydroxide, e.g., milk of magnesia, Phillips caplets, and sodium phosphate, e.g., Fleet's enema, lubricant laxative. Mineral oil is the only available agent in this class. It works at the colon to increase water retention in the stool.